Hello, I'm Dr. Steve Hutton. I'm a pediatrician at Summit Pacific Medical Center in Elma. I'd like to welcome you to the Summit Pacific Community Education Talks. This year, we'll be focusing on our talks for the youth of our community. Summit Pacific recognizes that to have the healthiest community in the nation, you must start life strong and healthy. It is our goal to provide everyone with information to build a good foundation necessary for the strong and healthy life. The information will be presented by a variety of speakers from coalitions and organizations that support Grays Harbor youth. Each talk will be recorded and posted on Summit Pacific's Facebook page. Please feel free to revisit these talks and share them. You can also ask questions using the chat box in the talk. We hope you enjoy the talk and find it helpful.
Hello and good evening, everyone. Tonight we are delighted to have Dr. Susan Stoner, who is a psychologist out of the University of Washington. And Dr. Stoner is a research associate professor at the Addictions, Drug, and Alcohol Institute in the Department of Psychiatry and Behavioral Sciences at the University of Washington School of Medicine. She completed her bachelor's degree in psychology at the Johns Hopkins University and her PhD in clinical psychology at the University of Washington, where she studied the effects of alcohol on social cognition. Since July of 2020, Dr. Stoner has been the director of the Washington State Parent-Child Assistance Program, which is a 3-year case management intervention for women who have used drugs or alcohol during their pregnancy. Thank you for speaking tonight, Dr. Stoner, and we're all excited to hear about your research.
Thank you so much, Cindy. I'm very happy to be here. Let me go ahead and start my slideshow. So the title of my talk this evening is Effects of Prenatal Substance Exposure on the Developing Fetus, from Fetal Alcohol Spectrum Disorder to Neonatal Abstinence Syndrome. Before we get started tonight, I would just like to begin by acknowledging that as we gather today, we are on the ancestral homelands of the indigenous peoples who've lived on these lands since time immemorial. I personally am broadcasting from West Seattle, and these lands are traditionally those lands of the Suquamish, Stillaguamish, Muckleshoot, Duwamish, and Coast Salish peoples. So please join me in taking a moment to express our deepest respect and gratitude for our Indigenous neighbors. So first, we'll review the learning objectives for my talk tonight. After attending this talk, it's my hope that individuals will be able to describe the effects of prenatal alcohol exposure on the developing fetus, compare and contrast effects of prenatal exposure to common drugs of abuse, and describe the etiology and treatment of neonatal abstinence syndrome. And in terms of commercial interests, I have no relevant commercial interests to disclose. So I'd like to start by talking a little bit about women's substance use. Substance use by women in their childbearing years, and by that I mean between the ages of 15 and 44, has increased yearly from 2016 to 2020. Looking at data that's published by the Substance Abuse and Mental Health Services Administration, or SAMHSA, with data collected during the annual National Survey on Drug Use and Health, what we see is that use of illicit drugs and marijuana has increased year after year since 2016. Whereas alcohol use has kind of held steady, and use of tobacco products has declined somewhat over time. Now, compared to men, women who use substances are more likely to become addicted from using smaller amounts for less length of time, more likely to have drug cravings, and more likely to relapse. Women are more sensitive to drug effects due to their hormones. And also, women have more physical effects of substance use, which result in higher rates of overdoses and emergency room visits. And so problematic substance use puts women at risk of victimization. And of course, the reverse is also true, where victimization puts women at risk of problematic substance use. And women who use substances are also at risk of sexual risk taking and unintended pregnancy. So while many women who use substances stop using substances when they become pregnant, they often don't know they're pregnant right away, so they may use early in the pregnancy. But if they have substance use disorders, they might find it difficult to stop using, even when they know they need to do so. And this might be especially true among women who have been victimized. And that would include those experiencing intimate partner violence or IPV, or those with a history of adverse childhood experiences, or also known as ACEs. So rates of substance use in pregnancy are concerningly high. Again, looking at data from the National Survey on Drug Use and Health, what we see is that alcohol use there at the bottom has remained kind of flat over the last 5 years. And the yellow line of tobacco products, you can see we've had some success in bringing rates of tobacco use down. But in the last 3 years, what you see is that after having some initial success in bringing rates of illicit drugs and marijuana use down, rates of use of these substances have increased over the last 3 years. And now you see the use of illicit drugs and marijuana almost on par with use of tobacco. So prenatal substance exposure puts children at risk due to possible effects of that prenatal exposure on prenatal health, fetal health and development. Also, likelihood of growing up in an adverse home environment where substances are used and there are related family problems potentially. And all that might culminate in the child being removed from the home. And having a child removed from the home puts mom at greater risk of problematic substance use. So this can be kind of a vicious circle. In fact, we see that substance use during pregnancy and substance use by mothers often occurs in the context of intergenerational cycles. So women who use substances during pregnancy often have a history of adverse childhood experiences, substance use disorder, and interpersonal violence. And of course, these three things are all related to each other, with adverse experience in childhood, predicting substance use disorder, and interpersonal violence in adulthood. And of course, substance use disorder and interpersonal violence in adulthood are certainly related. Now, together, these are associated with poor mental health, an adverse home environment, and unintended pregnancy. And of course, these things are also all related to each other. Now, this is all wrapped up in cycles of stress and coping, where being engaged in any of these things creates stress, and then efforts to cope can actually exacerbate the situation. So if you think about bringing a substance exposed child into this mix, that can increase stress. And then imagine putting on top of that loss of child custody, that can also really increase the stress on the family. I also want to note that these intergenerational cycles are sort of embedded within a broader social ecological context. So thinking about Bronfenbrenner's ecological framework for human development, we can think about these intergenerational cycles being embedded within kind of a context of the home environment, where you have the school, peers, family, work, and church, all potentially influencing the family. And then that family and immediate environment is embedded within a broader community, which is influenced by the availability of social services, mental health, access to substance use disorder treatment, medical care, and community services. So let's start by talking about the effects of prenatal alcohol exposure. Alcohol is the most studied drug of abuse in terms of prenatal alcohol effects, for a reason. Even back in 1996, it was realized that of all the substances of abuse, including cocaine, heroin, and marijuana, alcohol produces by far the most serious neurobehavioral effects in the fetus. And that was published in a report from the Institute of Medicine to Congress. And then decades later, the truth remains the same. Alcohol remains the most widely studied prenatal drug of abuse. Ongoing longitudinal studies continue to document long-term effects on growth, behavior, cognition, language, and achievement. Alcohol is the most common identifiable teratogen associated with intellectual disability. So I'm going to spend a lot of time in my talk talking about alcohol because that is the one substance that has the most significant effects on fetal development. So we know that alcohol freely crosses the placenta. 1 to 2 hours after the mother drinks, we find that fetal blood alcohol concentrations reach levels that are nearly equal to those of the mother. And then in addition, fetuses in the womb swallow amniotic fluid that contains alcohol, and then it gets into the fetus's gastrointestinal tract, where it has difficulty metabolizing. And that actually increases the exposure time to alcohol by the fetus. So really and truly, when a pregnant woman drinks alcohol, so does her fetus. Fetuses can't process alcohol the way adults can process it. The liver begins to develop in the first trimester. It really doesn't begin to perform normal filtration and digestive processes until later in infancy. So fetuses have undeveloped metabolic capacity. And with this undeveloped capacity, the fetus can't effectively eliminate alcohol on his or her own. The fetus has to rely on the mother's metabolic capacity. And what we find is that women's metabolic capacity varies widely, up to 8-fold from woman to woman. This might help explain why some fetuses are more likely to develop fetal alcohol spectrum disorders and others are less likely. So alcohol is a known teratogen, and by that I mean substances that have the potential to damage the fetus when exposure occurs during pregnancy. And with all teratogens, the degree of damage depends on the timing of exposure and the dose of the exposure. So if timing and dose are below the teratogenic threshold, the exposure may not cause any problems or malformation. The trick is sort of knowing where that threshold is. So prenatal alcohol exposure can cause death, malformation, growth deficiency, and functional deficits. So here we have a picture of mice. The one on the left was not exposed to prenatal alcohol, and the one on the right was. And just looking at it, you can see that there is a morphological effect of that alcohol exposure on the features of the mouse, and the same occurs in humans. Damage can occur in any trimester. There is no safe period of alcohol use. And there are just too many variables to estimate a safe amount. Like I said, it can depend on the woman's metabolic capacity, which can vary really widely. It can depend on the type of alcohol consumed, the timing of alcohol consumed, the amount, the consistency. It's very difficult to try to predict, and so we don't try to predict that. We just say there is no safe level of use. So fetal alcohol spectrum disorder refers to a spectrum of effects that can occur in an individual who has been exposed to alcohol prenatally. And it's kind of an umbrella term that covers a number of different sort of graded exposures to alcohol. So on the most severe end, we have fetal alcohol syndrome, and that's a term often applied to a constellation of effects observed with more severe exposure that includes facial dysmorphology. And I'll talk a little bit more about that in a moment, but there is a characteristic facial pattern associated with fetal alcohol syndrome. There's also something known as partial FAS, or partial fetal alcohol syndrome. This was a term coined by the Institute of Medicine in a 1996 report on FAS. And it was coined to refer to children who have some of the facial features of FAS, but not all of them, along with some evidence of growth retardation, neurodevelopmental abnormalities, or a complex pattern of behavior or cognitive abnormalities that are inconsistent with the developmental level that can't be explained by family background or environment alone. Fetal alcohol effects is a term that was coined to describe alcohol-exposed children who had similar patterns of cognitive difficulties, growth deficiencies, and mothers who drank heavily during pregnancy, but these children do not have the distinctive facial features seen in fetal alcohol syndrome. Alcohol-related neurodevelopment disorder is a term that is meant to refer to the neurodevelopmental abnormalities associated with prenatal alcohol exposure, or a complex pattern of behavior or cognitive abnormalities inconsistent with developmental level that can't be explained by family background or environment alone. And then alcohol-related birth defects is a term that generally is used to describe physiological abnormalities only. So fetal alcohol syndrome is a permanent birth defect syndrome that is caused by maternal alcohol drinking during pregnancy. Unlike some effects of prenatal substance exposure, it's generally not reversible. FAS is characterized by growth deficiency, as I mentioned, a unique pattern of facial features, structural, neurological, and/or functional brain abnormalities, developmental delay with intellectual impairment, and attention and behavioral problems. And it's worth noting that FAS is a leading preventable non-genetic cause of mental retardation. So here is a picture that illustrates some of the classic facial dysmorphology that we see in fetal alcohol syndrome. Typically, there are short palpable fissures, which is the distance between the corners of the eyes. There is a smooth philtrum, or the groove that is above the lip, and a thin upper lip. The nose might be a bit shorter than usual, and there may also be some alterations observable with the ears. But these three here are kind of the classic symptoms that we see. And brain damage that you don't see from prenatal alcohol exposure can be severe. And so what we see in this picture on the left is a 6-week-old baby's healthy brain. And on the right is a brain of a 6-week-old baby with fetal alcohol syndrome. So it's quite significant. Brain damage from prenatal alcohol exposure can also be diffuse, affecting a widespread area in the brain, almost every area of the brain. But again, there's high variability that depends on a number of variables, including the intensity of exposure. MRI studies of the brain find reduced brain volume, shape and thickness alterations in the corpus callosum, which connects the two hemispheres of the brain, alterations in the basal ganglia, hippocampus, amygdala, frontal lobes, among other areas. The basal ganglia generally affect cognition, emotion, and motor activity, and the frontal lobes are involved in executive function, abstract thinking, self-directed behavior, self-control, planning, that kind of thing. The corpus callosum, in connecting the hemispheres, is involved in communication between the two sides of the brain. These are some of the effects that we observe. And as you can see in this example MRI, this is the corpus callosum right here. So you can see alterations in the FAS brain. Prenatal alcohol exposure also affects the hypothalamic pituitary adrenal axis, which is sort of the home of our stress response. So in a normal person, what happens is stress affects the hypothalamus. The hypothalamus sends a signal to the pituitary gland, which secretes a hormone that acts on the adrenal gland, which in turn releases adrenaline to respond to the threat, as well as cortisol, which is our stress hormone. Now, most people, a little bit of stress is generally okay. It can help us perform better. But Weinberg et al. Have found that prenatal alcohol exposure causes the HPA axis to over-respond to even minor stressors with an over-release of the stress hormone cortisol. And this affects the body's response to stress and anxiety. So prolonged exposure to stress can be toxic without mitigating factors like protective relationships. And in someone with FAS, a level of stress that someone without FAS might not have a problem with can actually be quite problematic. So this kind of brings us to sort of the notion of fetal programming. It's something called the fetal programming hypothesis. And the basic idea is that antenatal events can program body and brain systems, which alters the fetus's developmental trajectory well into adulthood and increases vulnerabilities later in life. So we have prenatal development leading on into postnatal development across the lifespan. So when you think about prenatal exposures and factors affecting prenatal development, that can include maternal nutrition and health, of course, maternal substance use, also maternal stress and infection can alter prenatal development. Together, these things can result in fetal programming that affects prenatal development and sets it on a path that increases risk for, in adulthood, metabolic disorders, cardiovascular disease, immune dysfunction, and mental health disorders. So how common is FASD? In a first grade population, it's been found in the US that 1.1% to 5% have fetal alcohol spectrum disorder. And that might not seem like a lot, but when you think about it, that is actually more common than muscular dystrophy, cystic fibrosis, Down syndrome, and spina bifida combined. And adoptees and the foster system, we see higher rates. So about 6% of adoptees or kids in the foster system have fetal alcohol syndrome, and 17% have fetal alcohol spectrum disorder. Rates are even higher in the juvenile justice system, and that makes sense when you think about the effects that prenatal alcohol exposure has on the developing brain, where kids potentially are more likely to get into trouble if they have trouble sort of regulating their behavior. So 23% of kids in the juvenile justice system have been found to have fetal alcohol spectrum disorder. And in an adult criminal justice context, certainly more than 10% have fetal alcohol spectrum disorder. But in addition to that, 15% more adults met criteria for what you would observe with FASD, but prenatal alcohol exposure couldn't be confirmed. So it could be as high as 25% of people in the adult criminal justice system. So what we found with alcohol use during pregnancy is rates trending down with successful messaging. The campaigns have really spent a lot of effort educating the public about the dangers of drinking during pregnancy, and that is why we see that rates of drinking during pregnancy compared to rates of smoking and perhaps other illicit substance use is actually somewhat low. So rates of alcohol use have trended downward. And just to refresh your memory about that graph, you see here there's been some successful messaging with tobacco, and successful messaging with alcohol has kept rates relatively low. So just to summarize what we know about um, prenatal alcohol exposure and fetal alcohol spectrum disorder, there is no safe level of drinking during pregnancy that has been established. And not every woman who drinks will have a child with a fetal alcohol spectrum disorder. It really depends on the amount and frequency being consumed. So the more alcohol consumed and the more often the pregnant woman drinks, the higher the risk that she will have a child with FASD. What we found is the most harmful drinking pattern is binge drinking. And in a woman, binge drinking is generally understood to be 4 or more drinks on a single occasion. In the first weeks of pregnancy are the most sensitive, but the problem is that most women don't know they're pregnant at that time. And so that's why we look at rates of drinking in women of childbearing age, is that any of these women, if they're not using reliable contraception, could get pregnant. And if they are engaging in binge drinking, they could be doing that in the early weeks, and that's a sensitive period for FASD. But we also know that alcohol affects fetal brain development throughout pregnancy. It's not the case that you can start drinking later on in a pregnancy and things are going to be okay. No, that is not true. And we should also keep in mind that again, about 50% of pregnancies are unplanned, and so most women don't know they're pregnant for 6 to 8 weeks. So with that, let's move on to talk a bit about prenatal tobacco exposure. Tobacco has been the most commonly used substance, at least until recently. Maybe not for long. Again, sort of reminding you of that graph, you see that the rates are trending downward and really now are on par with marijuana use and illicit drug use, and alcohol use is actually below. So like alcohol, tobacco is teratogenic. And here's an example of a prevention campaign that was done by the CDC. And it does seem that that people are getting the message. But tobacco use during pregnancy carries risks to fetuses and can result in growth deficiencies, low birth weight, preterm birth, cleft lip or palate, as well as damage to the brain and lungs. These can be associated with feeding difficulties, breathing difficulties, breathing problems lasting into childhood, sometimes even cerebral palsy, or which is brain damage that causes trouble with movement and muscle tone, developmental delays, problems with hearing and eyesight. And then babies who are born premature may need to stay in the hospital for a few days, weeks, or even months. And risk persists after birth. Children exposed to tobacco and nicotine in the womb are at higher risk of sudden infant death syndrome. And of course, they have all of the risks that go along with being a preemie if they're born premature. So that's alcohol. Let's talk a bit about prenatal cannabis exposure. So prenatal cannabis exposure is second only to alcohol and tobacco as the most commonly used drug during pregnancy. And as you know, legalization is spreading across the country, and the risk is that legalization sends a message that use is safe. Although we know, like alcohol and tobacco are also legal, but just because something is legal doesn't mean it's safe. And yet, we hear from pregnant women that they believe that marijuana is benign and that use is safe. It is not. So past 30-day use has been increasing since 2018, as I showed you in that graph. And among those who used in the past year, 16%, or about 1 in 8, used almost daily. So women who are using marijuana are often not just using it here and there. They are using it regularly, consistently. And as we know, the more frequent and intense the exposure to a substance, the more likely that there are going to be problems associated with prenatal exposure. So like alcohol and tobacco, cannabis compounds cross the placenta to the developing fetus. So tetrahydrocannabinol, THC, which is the psychoactive chemical found in marijuana, it crosses the placenta rapidly. And this is the chemical formula right there. THC concentrations in the fetus are about 1/3 of the levels found in the mother. And THC can be detected in the mother's urine for weeks, depending on the potency, frequency of use, metabolism, and other factors. And we know that with legalization and methods of growing cannabis, that the concentration of THC has been increasing over the last several decades. So the THC that infants are being exposed to, or fetuses are being exposed to today, is very different than the cannabis that they may have been exposed to in the past. And we don't have good research on that type of exposure. It's also important to realize that THC is only one of many compounds in cannabis that may affect a fetus. And we don't know about most of them, what kind of effects they have. So some of those compounds in marijuana are non-psychoactive, but non-psychoactive does not necessarily mean safe. Right now in particular, I'm talking about cannabidiol, or CBD. It is not psychoactive, but it's not necessarily safe. And here's the chemical formula. Unfortunately, there is no research on the effects of CBD on the human fetus. But in animals, high doses of CBD in pregnancy have caused problems with the reproductive system in male fetuses. It's also important to realize that CBD products might be contaminated with substances that might pose a risk to the fetus, like fungi, other pesticides, heavy metals, and things like that. And those can affect the developing fetus. In fact, CBD has known risk to adults, and those risks include liver toxicity, extreme sleepiness, and also harmful drug interactions. So CBD is not without risk. So what do we know about the effects of prenatal cannabis exposure? Studies have linked it to growth deficiencies. So effects have been reported for decreased birth weight, small gestational age, and preterm birth. It's also been associated with stillbirth. So pregnant women who smoke marijuana have been found to have 2.3 times the risk compared to women who don't smoke marijuana during pregnancy of having a stillbirth. But it's important to realize that findings vary depending on the study design and also whether other prenatal drug use is taken into account. So often people who use marijuana during pregnancy, that's not the only thing they're using. They may also be using alcohol and or nicotine, if not other illicit drugs. So it's very difficult to tease apart the effects that are attributable to one substance alone. It's also important to realize that cannabis smoke is similar to tobacco smoke in terms of having some harmful compounds like carbon monoxide. So we would expect to see some similar effects from cannabis smoke as we see with tobacco smoke. In addition, most studies that have looked at the effects of prenatal cannabis exposure have reported some subtle effects on neonatal brain function. And these include deficits in regulatory behavior and habituation. And by that, I mean the ability to quickly decrease sensitivity to noise or light, kind of getting used to that. What you see is those with prenatal cannabis exposure sort of trying to get away from bright lights or noises more than non-exposed infants. We also see higher levels of irritability, fussiness, excitability. There's also increased startle response and tremors. However, at this time, we really don't have any data to demonstrate that whether there is a clinical withdrawal syndrome associated with marijuana exposure. The jury is still out on that. But we do find that prenatal cannabis exposure is associated with increased placement of newborns in the NICU. Again, we don't know for sure if that is specifically related to cannabis use or if there are other drugs that might help to account for that. So let's move on and talk about prenatal stimulant exposure. First, I want to point out that rates of stimulant use are low and generally holding steady. So coming back to that graph we've looked at, I've added here rates of stimulant use. So you see well under 1% using stimulants, cocaine, methamphetamine. So not nearly as common as marijuana or alcohol, or certainly tobacco use. Back in the 80s and 90s, there was great concern about crack babies. But it turns out that a lot of the fears about crack babies ended up being unfounded. While it is true that prenatal cocaine exposure slows fetal growth and affects neurodevelopment, those effects largely disappear in childhood. Kids tend to grow out of those effects. However, prenatal cocaine and crack use, to the extent that they're associated with poverty and stress during pregnancy, those can actually have a greater impact on childhood development. And it's also important to realize that illicit drug use during pregnancy is associated with poor prenatal care. Moms who are using illicit substances are often kind of driven underground due to stigma and shame, and they may not seek needed prenatal care. And that can help to account for some of the effects that we see in newborns. So talking about methamphetamine, similarly, there has been a great concern about meth babies, but also similar to cocaine, it seems like some of those fears, the degree of those fears are maybe not as extreme. Certainly prenatal meth exposure has been shown potentially to slow fetal growth and affect neurodevelopment. And in rats, prenatal meth exposure has been shown to cause increased mortality in both the mother and the child. Retinal defects, cleft palate, malformation of the ribs, and delayed motor development. However, in humans, prenatal meth exposure is not consistently related to birth defects. But looking at this picture, what do you see? Not only is this woman smoking meth, she's got a cigarette in her hand. So again, I just really want to drive home the point that using just a single substance is actually quite rare, and that makes it pretty difficult to determine the impact of any single drug on fetal development. So let's talk a bit about prenatal opioid exposure. Rates of opioid use relative to those of alcohol and marijuana use are low, and they are actually declining in the last few years. So coming back to our graph, we have our rates of marijuana and binge alcohol use, and you see there was an increase of consistent with the opioid crisis of opioid use during pregnancy, but that has been coming down over recent years. According to the CDC, the number of women with opioid-related diagnoses documented at delivery increased by about 131% from 2010 to 2017. But it seems like it's really kind of started to decline since then. So according to 2019 self-reported data, about 7% of women reported use of prescription opioid pain relievers during pregnancy. But of those, only 1 in 5 reported misuse. And by that, I mean getting prescription opioid pain relievers from a source other than a healthcare provider or using them for a reason other than to relieve pain. So effects of prenatal opioid exposure include, well, first of all, opioid use during pregnancy is associated with maternal death, and that obviously is problematic for the developing fetus. But also, opioid use disorder, again, is associated with poor prenatal care. Moms with OUDs are, due to the stigma, often kind of driven underground and avoid prenatal care. But prenatal opioid exposure has been linked to poor fetal growth, preterm birth, stillbirth, neural tube defects, congenital heart defects, as well as congenital musculoskeletal malformations. For a long time, there was concern about giving opioid replacement medication during pregnancy for moms with opioid use disorder. However, opioid replacement medication has not been found to cause birth defects. And so increasingly, we're seeing medication-assisted treatment or opioid medications for opioid use disorder being provided to pregnant moms, as getting them stable on medications is ultimately, in the long run, less problematic than sort of an uncontrolled addiction. It's also important to realize that opioids in pregnancy can lead to neonatal abstinence syndrome in some newborns. So let's talk about that a little bit more. What is neonatal abstinence syndrome? So NAS refers to a constellation of conditions that can occur when newborns withdraw from substances, particularly opioids. And some symptoms that might be observed in a newborn include tremors, fussiness, excessive or high-pitched crying, sleep problems, hyperactive reflexes, seizures, yawning, stuffy nose or sneezing, poor feeding and sucking, vomiting, loose stools, and consequently dehydration, increased sweating, and breathing problems. Signs of withdrawal usually begin within 72 hours after birth. And the severity of withdrawal is going to vary with type, intensity, and recency of exposure to the substance. Withdrawal from opioids during the first 28 days of life is called neonatal opioid withdrawal symptom, or NOWS. And this occurs after long-term exposure to opioids. It's not caused by opioids given at the time of delivery, which are pretty circumscribed. But for newborns with NOWS, we find longer hospital stays after birth, rehospitalization, increased likelihood of rehospitalization within 30 days of birth, developmental delay, and also speech or language impairment into early childhood. Again, it's unclear if this is due to opioid use specifically or other environmental factors, such as not receiving adequate prenatal care. So how do we treat neonatal abstinence syndrome and NOWS? So there's a scoring system to grade the severity of withdrawal, and urine and meconium are tested for drugs so that healthcare providers can identify the drugs from which the newborn is withdrawing and be able to provide appropriate medications. In the case of opioids, we have opioid medications to manage withdrawal symptoms, and then the newborn is weaned over time. In addition, the newborn is typically treated with IV fluids to prevent dehydration and higher calorie formula to counteract the lower birth weight that is often seen in substance exposed newborns. And then typically, mom and baby are roomed together, and healthcare providers monitor the eating, sleeping, and consoling. It's recommended that moms and infants have skin to skin contact and that moms breastfeed on demand. And then, in addition, just comforting and consoling the baby using swaddling, gentle rocking, and sort of maintaining a quiet environment for the newborn to sort of come through the withdrawal syndrome. Now, most babies get better within 5 to 30 days. So, in summary, just to sort of reflect on what we've talked about today, when it comes to the effects of prenatal substance exposure, alcohol is the most studied and the most problematic by far. Um, But it's important to realize since it's common for people to use multiple drugs, it's really difficult to tease apart the effects of single drugs. And that's why we really need more research that is able to isolate the effects of single drugs and prenatal exposure to those drugs. Based on what we know now, compared to other substances, prenatal alcohol exposure has the most significant impact, and it's potentially lifelong, irreversible. And cannabis use may not be as benign as many women assume, despite being legal. However, thus far, no long lasting impact or withdrawal syndrome has been identified with cannabis. Um, Oops. But both THC and CBD can impact developing fetuses. So even a CBD that you can buy over the counter in states that don't have legalized marijuana is potentially problematic. Effects of prenatal stimulant or opioid exposure appear to wane over time. And it actually may be environmental conditions associated with illicit drug use that have a greater impact on the developing child, including poverty, instability, and poor prenatal care. So it's really important to work with moms who are pregnant and using substances to help them address not only their substance use, but also these issues. And doing that should benefit both the moms and their children. And it's really important that we never forget that the moms themselves really matter too. So that is all I had for you today. Are there any questions? Are topical CBD creams also dangerous? That's a good question. I'm not aware of any research into topical CBD creams in pregnancy, although transdermal substance use, I think, is generally results in lower concentrations in the bloodstream, and it acts more locally. So, it might depend on where the CBD cream is being used. If it's being used near the vagina, that is potentially more problematic than being used, say on the hands. Um, but I'm really not aware of any specific research related to that. Any other questions? Okay, great. All right. Well, thank you so much for inviting me to speak today. I hope that we've met the learning objectives and that you are able to understand the effects of prenatal alcohol exposure and contrast that with other drugs.